Opgen-Rhein will be presented this experience about the Rashkind operation. Please.
Thank you, Professor Alexi. Dear ladies and gentlemen, dear colleagues, I'm very pleased about the opportunity to hold this talk because the Rashkind Ballon arterioseptostomy in transposition of the great arteries is maybe a little bit older than me, and it's the kickoff of pediatric interventional cardiology, so it's a pleasure for me. A short view back in the history shows us the natural history of simple transposition, and I will focus this talk on simple transposition. We see here the life expectancy in this situation in the natural course, and we have a 50% dying in maybe the first months, and nearly no survivor through the first year of life, and the reason is hypoxemia in the main. Back to the history, Professor Alexi told us so much about it. Just to see the setting again, when William Rashkind proposed Ballon arterioseptostomy in 1965. We have, after the introduction and acceptance of this technique, we have already a preoperative mortality around 20%, up to the mustard or Senning correct operations. This seems to be a little bit different today. With the help of the prostaglandin therapy up to 1976 and the introduction and acceptability of the atrial switch operation with earlier neonatal corrective surgery, we still have a mortality around maybe 4%, but exact data are missing here. Just back to the original paper, we saw it in the last talk with the balloon of William Rashkind, published in 1966. Here, 1968, he proposed his first results in showing that he will reach a better oxygen saturation in nearly all patients and decompression of left atrial pressure. When introduced, this technique was the most important single factor influencing the survival in patients with transposition. 1982, we will find the first papers around about bedside arterioseptostomy using echo, and this is usually a picture we see today in nearly all cases. I feel much more comfortable with visualization of the balloon in echo than in B-plan angiography. Here we see the result of this successful balloon arterioseptostomy with a wide intra-atrial communication and without restrictive flow from the left to the right atrium. So the next question is, what about complications? It's very interesting to see what the literature tell us about complications. We found a lot of single case reports about perforations. There are a lot of possibility sites of perforation of the heart, valvular damage, especially the mitral valve, vascular damage like disruption of the vena cava inferior. I found one report of rupture of the ductus arteriosus. I never suspect arrhythmias are of some concern, and venous thrombosis if you use the femoral venous approach. But what we didn't have are any incidences, despite the fact that this procedure is carried out for around 40 and more years. The estimation for severe complications we use is around 1% of all interventions. There's one more complication, and that is stroke, and I will focus this talk later on this topic. We will have a change of perspective in the treatment of transposition of the great arteries from survival to the possible best neurodevelopmental outcome, as we expect a survival in more than 90% of cases with simple transposition and a good functional outcome in the midterm. So, and that's what's about some concern. It's a paper from 2006. After a long term, we don't have anything to read about atrioceptostomy. We found this paper from McQuillan from San Francisco and Vancouver, who showed us periventricular leukomalacia here and cerebral infarction over here in preoperative MRI studies in patients with a simple transposition. Here are the data. 29 infants are studied with preoperative MRI, and we see a high number of acquired brain injury. Nearly half of the patients, maybe 40%. And all these neonates with acquired brain injury has an atrioceptostomy, 100%, and only no brain injury were found in patients who had only 41% of prolonged atrioceptostomies. So they concluded that the prolonged atrioceptostomy was a significant risk factor for acquired preoperative brain injury in these neonates. Some concern are that this is, to keep it in mind, this is not a randomized trial. These infants here, which get the prolonged atrioceptostomy, are those who needed them. After this, as a kickoff for this new discussion, there are a lot of papers coming up to us. This is from PT 2009, who shows us, again, MRI studies preoperative and found no infarctions, only these white matter injuries, periventricular, and couldn't get an association to the balloon atrioceptostomy with the same incidences of white matter injury in both groups. Again, here we see the risk for development of white matter injury, PVL, was found in these infants which has the same PO2 pre and post balloon atrioceptostomy. So here we conclude that hypoxemia is more reason for white matter disease than the balloon atrioceptostomy as well. Here are the MRI data from this working group. We only see these white spots here as white matter disease and no strokes. Again, the next group is this one, published in 2010. These are database recordings from America. Only ICD codes are used, so we will find only clinical strokes in here and not subclinical like in the MRI studies. But what we can see here is we have strokes in 1.4% of the neonates with transposition with septostomy and 1.4 in the babies without septostomy. So here's no association between these. Again, a next study from Baker, published in 2009, showed us, I just have to see, the same thing of brain injury, white matter injury, with the same incidence of balloon atrioceptostomies in infants without or with brain injuries. Interesting here from this Australia working group is that they find a high incidence of these white matter lesions in around 30% of the studied babies, and this has been shown to have the same incidence in patients with hypoplastic left heart or pulmonary atresia. Again, there's a nationwide study from the United States using database recordings of 8,681 neonates with transposition. And what we see here in this retrospective database recording, only suspecting clinical strokes, is that we have an incidence of strokes of 0.35 in patients without Rashkind procedure, and maybe the double, 0.6 or 7% in neonates with balloon atrial septostomy. On the other hand, there's a trend for better survival in patients undergoing Rashkind procedure. So at last, we have a review article published in 2011 from Polito from Rome, who surrogate these studies and came to this meta-analysis, shows us that in view for acquired brain injury, there's always no data to abolish balloon atrial septostomy. So this meta-analysis shows a trend towards a positive effect in reducing the number of especially white matter injuries. So in summary, there's a possible association between Rashkind's balloon atrial septostomy and preoperative stroke, but however, there's no proof of causality. There's no randomized trial in this intervention, and all these studies showed or performed balloon atrial septostomy in severe hypoxemic infants. And what has been shown that hypoxemia is still a risk factor for white matter injuries and adverse outcome. So the impact of balloon atrial septostomy is again showed here by Harmas in 2011, who has 3 groups of patients. The group 1 didn't receive balloon atrial septostomy. The second one has a successful balloon atrial septomy with discontinuation of prostaglandin treatment over some days. And the third group has balloon atrial septomy who needed a standard dose prostaglandin up to operation. And what we see here is the postoperative course is much better in the atrial septostomy group with and without prostaglandins than in the non-atrial septostomy group. Maybe this is an argument for further using a balloon atrial septostomy. On the other hand, there's something worked on. It's something like fetal risk stratification. You can find it in Journal American Society of Echocardiography 2011. The colleagues showed us that we can found a risk situation in prenatal or fetal ultrasound with this pattern of ductal flow and this pattern of hypermobility of the septum primum, which puts the infants at risk for deep hypoxemia after birth. Interestingly, the hypothesis behind this is that the streaming of oxygen-rich blood from the ductus venosus is directed through the foramen ovale to the pulmonary circulation in transposition and leads to vasodilatation. And this is something we can see here. And this vasodilatation leads to a rise in left atrial pressure and thickening of the septum primum and maybe to a very tiny PFO after birth. So these infants may be at risk for deep hypoxemia and needs an urgent balloon atrial septostomy. Okay, yeah, here we see, the septum primum moving very hypermobile from the one atrium to the other. I think I'm running out of time. Our institutional publicity is something I call it's, we perform early routine balloon atrial septostomy in simple transposition between the doors. So we perform it in nearly every neonate just after the primary, after leaving the neonatologist, the reanimation room, and just before entry in the neonatology ward. So we are very early in treating these infants. What we do is we administer prostaglandin soon after birth for balloon atrial septostomy after echocardiographic improvement of the diagnosis. So I'm talking mainly about inborn babies with prenatal diagnosis. We try to sedate those babies without intubation and use the umbilical venous approach first. After failure to find the way through the ductus venosus, we change to the femoral venous route with a 5 to 6 French sheath. We administer heparin on a routine basis and perform the balloon atrial septostomy with a stepwise increase of balloon filling. After successful atrial septostomy, we try to wean the prostaglandin down to a minimal dosage of maybe 6 nanogram per kilo a minute and leave this up to the operation. Maybe we didn't perform atrial septostomy if we have a large true ASD with unrestricted shunt and a high saturation before. So we use these two balloons. This is a new MedSat 5 balloon with 1 and 2 milliliters filling volume, or the Medtronic Rashkind catheter. This is something we can discuss. The Medtronic balloon has for us one advantage is a soft and round tip, which makes it very easy to maneuver in the portal vein through the ductus venosus to the right atrium, and it needs no sheath. I didn't like the balloon because it's very compliant. The second catheter, the Z5, needs a sheath and needs a sondation with different catheters first, but you can use the over-the-wire concept in difficult PFOs, and we have a more rigid, non-compliant balloon. Sometimes in special situations we use static balloon dilatation of the foramen ovale, especially in very small birthway babies or in a situation of very rigid septum primum. And we have one situation of stenting of the foramen ovale in a premature baby growing up to 1.9 kilo and have again a restrictive PFO with high pulmonary pressure and desaturations on a palliative basis. Our experience so far in the last 5 years, we performed 60 procedures in 57 neonates with a medium weight of 3.1 kilogram. The smallest maneuver was done in this preterm baby as shown before at a weight from 1.3 kilogram. 51 procedures were done in the first hour after birth. These are our inborn babies. There are some procedures and in babies we get from other hospitals, so we are later in performing this balloon atrial septostomy. 93% we perform only at bedside with echo imaging only. True procedures are done secondary under fluoroscopy because of difficulties in passage of the foramen ovale. 2 procedures are done primary with fluoroscopy, and this is a very tiny low birth weight infant. 72% of these interventions are worked out through the umbilical vein, and we did 3 static balloon dilatations and 1 stent implantation. If you review the indications, the pre-interventional saturations has been below 70% in 36 patients, In the others, the saturations are still better before atrial septostomy. Nevertheless, the mean saturation has been 63% pre-atrial septostomy and rises to 80% post-intervention. We have a failure of the procedure in 4 patients which required a redo or a change of location to the cath labs. Here are our complications. We see a very large number of transient rhythm disturbances like heart block, sinus bradycardia, or atrial flutter. All of these has been transient and could be managed without greater problems. This is in around 18%. Severe complications has been seen maybe in one patient who died despite reanimations method 1 hour after very easy and successful balloon atrial septostomy due to unexplained massive air embolism. We didn't understand this case. There is an umbilical line in place and we don't know where the air comes from, but it's a massive air embolism which which we can't manage at all. Again, from the 57 neonates, 55 survived until the operation on day 3 to 13. 45 neonates have a very uncomplicated course after this very early balloon atrial septostomy with no respiratory problems, no intubation, and no lactate acidosis and stable saturations. Prostaglandins could be weaned to a minimal degree like in our protocol. And we have only 1 neonate who remained in persistent pulmonary hypertension requiring ventilation with nitric oxygen up to the operation. After all, we see clinical 3 cerebral hemorrhage, but this has been detected only post-operation. We didn't perform any MRI in our infants, but on a regular basis they get ultrasound of the cerebrum post-intervention and pre-operation and post-operation, and this is the only 2 complications we see in this thinking. Open questions are left. What is the lowest tolerated saturations? Is it a measurement of lactate acidosis who will give rise to concern about the saturation, or is it a fear for a white matter injury? We didn't know it exactly, so we put our goal at 70 to 75% minimum saturation. Is an emergency atrial septostomy on a hypoxemic infant better than do it elective? We don't know. And what is the best timing for atrial switch? There are some data who prefer a very short interval from birth to corrective surgery. My personal conclusions so far, I think it's still reasonable to perform early elective atrial septostomy in simple transposition. And I'm not so convinced about the association of atrial septostomy and cerebral stroke. I have more concerns about hypoxemia and cerebral status and white matter injury. But nevertheless, we need further studies for better understand what would be the burden of this intervention and what is the optimal treatment. Especially, I think we need a randomized trial in infants where we can go both ways. We can perform maybe only emergency atrial septostomy and have a wait-and-see procedure, and on the other hand, an elective atrial septostomy. And we have to perform MRI before and after atrial septostomy to clear these problems. I thank you very much.